back to Open Med School. Today I am going to discuss with you about an important topic, upper GI bleed. So this is as three parts. We'll start with the introduction, definitions and causes of upper GI bleed in the first session. So what is upper GI bleed? Upper GI bleed refers to blood loss originating from a source proximal to the ligament of Treitz. So this is the landmark. So what is ligament of Treitz? Ligament of Treitz is a folded peritoneum that connects and supports the end of duodenum and beginning of jejunum. It is sometimes called the suspensory muscle of duodenum. So that is the ligament of Treitz. So here you can see the ligament of Treitz. So this is the fold of peritoneum that is attached to the end of duodenum and beginning of the duodenojejunal flexure, and that is one of the very important landmark. So proximal to this region, blood loss is called upper GI bleed. This is another picture showing the ligament of Treitz. So upper GI bleed is bleeding proximal to the ligament of Treitz. So now we'll look into what are the clinical presentations. The most common presentation is hematemesis, that is fresh blood vomited out. Some days it can be coffee ground vomitus. This occurs because of the formation of acid hematin. So these are the two common presentation. Another one is Melena. Melena is black tarry stools with a characteristic foul smell. So dark stool is not always called or is not Melena. Melena is dark tarry foul smelling stool. Rarely hematogasia, that is fresh blood per rectum, can also occur. So even though it is a characteristic feature of lower GI bleed, this can occur in massive upper GI bleed. And sometimes non-specific symptoms, especially patient presenting with giddiness, or in chronic cases they may present with a pylori. The non-specific symptoms are again important because somebody faints in the bathroom, brought to the casualty, or even there can be loss of consciousness or a convulsive syncope can occur with a upper GI bleed. That is the importance of the non-specific presentations. Now we look into the history of a patient. It's a 65-year-old female. Chief complaint is Melena. So as mentioned, Melena typically results from bleeding proximal to the ligament of Treitz and require minimum 50 ml of blood. And approximately 14 hours is required for the formation of Melena. So the Melena formation takes time. So that is the point to be kept in mind. The patient had sweating and giddiness also. So what are the things you will ask in the history? So most important, you should ask about the use of analgesics. So patient was on diclofenac sodium intermittently, is a hypertensive, type 2 diabetic. Medication history is very essential, especially antiplatelet drugs. So NSAIDs and antiplatelet agents are significant risk factors for GI bleeding, especially due to peptic ulcer. In addition, you should think about the other major causes like portal hypertension, about which we will come to at a next later stage. So the past history, the patient had vague epigastric discomfort and 10 kg of weight loss in last 6 months. Weight loss is an important history because this may point towards the possibility of malignancy. So the examination, vitals, the supine BP 120/80 and the sitting it is 160. All patients with a normal or BP more than 100, you should make a standing blood pressure recording, or looking for the orthostasis. On standing, blood pressure systolic falling more than 20 and diastolic more than 10 is very significant. In the case, 10 to 20% of the blood volume is lost. Pale conjunctiva, this may indicate that patient had previously earlier loss of blood. Anectric sclera, jaundice can be present in patients with portal hypertension or cirrhosis. And a digital rectal examination is recommended in case of upper GI bleed for identifying Melena. So one of the important things you should look for is the bowel sounds. The blood is there, significant blood, usually you get a hyperactive bowel sounds. So often neglected in the clinical examination is auscultation of the abdomen in case of upper GI bleed. When there is a significant bleeding, usually you get a hyperactive bowel sounds. So now we go to the presentations. There can be two types of presentation. One is the upper GI bleed. Second is the non-specific symptoms. We have already said the non-specific symptoms can be hemodynamic instability. That is, the patient may be presenting because of the hypotension, tachycardia, can have epigastric pain, fatigue, lethargy, syncope, and pallor. Already mentioned about the hematemesis, coffee-colored emesis, and Melena. So, a small mnemonics you can remember by using varices. V stands for esophageal varices, A for alcohol and drugs, R for rupture, that is Mallory-Weiss Tear. No cause is seen in some cases, carcinoma of stomach, esophagitis, and peptic ulcer or stomach ulcer. So these are the common causes. So the clinical significance of Melena suggests upper GI bleeding, requires a degradation of blood, usually more than 14 hours in the GI tract is required, and may require at least 50 up to 100 ml. The Melena may not be present. So blood, as most important point to remember, is blood must be present for at least 14 hours for to be converted into Melena. So that is one point to be kept in mind. Then differentiating upper GI bleed from lower GI bleed is often not a problem. Just for the completion, the source we already mentioned, esophagus to duodenum. The lower GI bleed, jejunum to rectum. Melena is very important. Vomiting of blood. Blood urea nitrogen is increased in case of upper GI bleed because the blood contains a lot of protein, and this will lead on to rise in blood urea nitrogen. Another important clinical finding we already mentioned is the hyperactive bowel sounds. So the etiology of GI bleed we can divide into one arterial bleeding and a venous bleeding. Venous bleeding is typically in cirrhosis of liver, in Budd-Chiari syndrome and splenic vein thrombosis. This is a venous bleeding. Arterial bleeding can occur in peptic ulcer disease, the Mallory-Weiss Tear, gastritis, neoplasms, pseudoaneurysms, aortoduodenal fistula, trauma, hemophilia, and sometimes in pancreatitis. So depending upon the etiology, you divide source of bleeding. It can be arterial bleeding and venous bleeding. Now we go into a little more detailed account. This is a list of conditions that producing pain. This is a lot of conditions are there, of which remember the peptic ulcer disease is the most frequent, around more than 55%. More than 50%, even in case of varicose patients with the varices, it is peptic ulcer disease. That is important point to be kept in mind. So other conditions we'll be discussing later. So two more important things. One is Osler-Weber Rendu. So this can present as from the esophagus or from the upper or from the stomach they can get a bleeding. So it is essential to look at the mucosa, oral mucosa under the tongue, looking for telangiectasia. Another is the Dilated lesion. So this is a rare condition. Dilated tortuous submucosal artery that protrudes through the gastrointestinal mucosa. It is a potential cause of upper GI bleeding, occur any part of digestive tract, but most frequently in the stomach. So here you can see the lesion. There is a artery, submucosal artery that is protruding. So sometimes you may come across with this lesion. Again, remember the common causes. The first and foremost is peptic ulcer disease. 50%, more than 50% is peptic ulcer disease, and yes, pylori is one of the implicated factors. Next is the esophageal varices, an enlarged tortuous portosystemic communications at the lower end of esophagus or a gastroesophageal junction. And again, remember that in portal hypertension, the bleeding is due to portal hypertension rather than coagulopathy. So there's a concept that you should keep in mind. So coming to the common causes, start from the anatomically. Esophagus, the reflux esophagitis around 2 to 5%, the varices around 20%, and the Mallory-Weiss Tear is an important point. Whenever there is a retching, it can produce 5 to 10% recurrent vomiting, and sometimes even the first episode of vomiting, we can get a tear at the gastroesophageal junction. Mallory-Weiss is one of the very important cause for upper GI bleed. Then the peptic ulcer disease, we already mentioned, around 50%, more than 50%, in some studies up to 70%. And even in patients with esophageal varices, the cause may be due to peptic ulcer disease. Carcinoma of stomach is an uncommon thing. Then portal gastropathy and erosions, peptic ulcer and gastric erosions, again important. So what are the 4 or 5 major causes if you look? Peptic ulcer disease, second is varices, third is Mallory-Weiss, fourth is the gastric erosions, right, due to drug induced or alcohol induced. And again, remember, in patients with hospitalized stress ulcers may be cause of bleeding. And in cirrhosis, remember, varices has the important differential diagnosis. So we'll repeat once more the common causes: peptic ulcer disease, esophageal varices, Mallory-Weiss, angiodysplasia, vascular malformations. Others are the gastritis, cancer, Dilated lesion. So today we have discussed about the definition of upper GI bleed. What are the common causes? In the next session, we'll be discussing how to assess the severity of upper GI bleed. Hope it was useful. Stay tuned. Thank you.